Let's dive right into this explainer on high-yield therapeutic drug monitoring for Step 2 CK. Before prescribing any high-risk medication, we always need to evaluate renal and hepatic clearance, narrow therapeutic indices, and potential drug interactions.
Today's agenda covers renal impairment and drug safety, warfarin reversal, heparin and DUAC management, perioperative bridging, anti-epileptics, and finally, lithium and digoxin toxicity.
Section 1. Renal impairment and drug safety. Before writing that prescription for a high-risk drug, you've got to determine if it's renally cleared. A decreased GFR means we're adjusting the dose or substituting the drug entirely.
For example, look at a patient with severe renal insufficiency, specifically a GFR below 30. Here, unfractionated heparin followed by warfarin is your preferred strategy. Why? Well, low molecular weight heparin and factor XA inhibitors are renally cleared. If you use them, they'll just accumulate and cause major bleeding. So you've absolutely got to substitute unfractionated heparin.
When dealing with severe overdoses of narrow therapeutic index drugs, think lithium, sodium valproate, or carbamazepine, immediate hemodialysis is often mandated. You simply cannot wait around for the kidneys to clear these out if the patient is severely toxic.
Moving to Section 2, warfarin reversal and interactions. Your management and INR reversal decisions here are going to depend entirely on the presence and severity of bleeding.
Let's break down the logic. If a patient's INR is above 10, but they aren't bleeding, you hold the warfarin and administer high-dose oral vitamin K. But if there's serious or life-threatening bleeding at literally any INR level, oral vitamin K just won't cut it. You have to reverse immediately using IV vitamin K plus prothrombin complex concentrate.
And don't forget to constantly monitor for CYP450 interacting drugs. It's a classic exam trap. Inhibitors like NSAIDs, amiodarone, and SSRIs will increase warfarin's effect, spiking that bleeding risk. On the flip side, inducers like rifampin and carbamazepine rev up the metabolism. That decreases warfarin's efficacy and puts the patient at risk for thrombosis.
Section 3 is heparin and DOAC management. Your approach shifts significantly when dealing with pregnancy or certain hypercoagulable states. Take pregnancy, for instance. Unfractionated heparin becomes the anticoagulant of choice right before delivery because of its rapid reversibility. Now, while low molecular weight heparin is commonly used throughout the pregnancy itself, remember that all anticoagulation has to be stopped the moment labor begins to prevent massive hemorrhage.
Then there's type 2 heparin-induced thrombocytopenia, or HIT. If you see a platelet count drop by more than 50% after 5 days of heparin exposure, stop all heparin products immediately. You need to start a direct thrombin inhibitor like argatroban or fondaparinux right away. Do not wait for the confirmatory testing to come back.
Next up is Section 4, perioperative anticoagulation bridging. These decisions boil down to weighing the surgical bleeding risk against the patient's thromboembolic risk.
For patients with preoperative atrial fibrillation, handling DOACs is pretty straightforward. Just stop them 1 to 3 days before surgery. No bridging needed. Vitamin K antagonists, like warfarin, though, require a 3 to 5 day hold. And you only bridge with heparin if the patient has a moderate or high thromboembolic risk, like if they have a mechanical valve.
Section 5 covers anti-epileptic drugs and status epilepticus. We apply that exact same next best step logic to neuro.
When you're evaluating a first-time or breakthrough seizure, your very first step is checking medication adherence and baseline anti-epileptic drug levels. Do this before you even think about escalating therapy. Make sure to rule out metabolic triggers first by checking blood glucose, electrolytes, and running a tox screen.
If a seizure lasts beyond 5 minutes, we're in status epilepticus territory. First, stabilize those ABCs, then push IV benzodiazepines. You follow that immediately with an adjunctive IV anti-epileptic, something like levetiracetam or fosphenytoin. If the patient is still unresponsive after all that, continuous EEG monitoring is strictly mandated. You have to figure out if it's just lingering sedation or if they're in ongoing non-convulsive status.
Finally, Section 6, lithium and digoxin toxicity. We're looking at narrow therapeutic index drugs that are highly susceptible to renal impairment.
Lithium clearance is strictly renal. That means literally any factor that decreases renal perfusion is going to trigger acute toxicity. Common culprits like dehydration, NSAIDs, ACE inhibitors, and thiazide diuretics will cause those lithium levels to spike rapidly.
Acutely, this decreased clearance shows up as gastrointestinal distress, but chronic toxicity, that presents with late neurologic sequelae. Think ataxia, lethargy, confusion, and tremors. Recognizing these signs means you need to initiate prompt intravenous hydration or even hemodialysis in severe cases.
Digoxin is another classic renally cleared drug where toxicity is famously worsened by underlying hypokalemia and kidney injury. With digoxin, severe gastrointestinal distress often precedes lethal cardiac arrhythmias. So if you suspect toxicity, you absolutely have to check a potassium level and get an ECG right away.
Let's solidify this core concept. Low molecular weight heparin and factor XA inhibitors are strictly not recommended in renal insufficiency because they are metabolized by the kidney. Remember to always choose unfractionated heparin over low molecular weight heparin when your patient's GFR falls below 30.